basically warm welcome. And listening to who's sitting around the table, I feel really humbled because I would just love to hear more about every one of your projects. There's a huge amount to learn. So you asked me the question about growing up in Northern Ireland. Well, I grew up and I was 10 years old whenever the troubles started. And I think what was interesting about that was even as a small child, you could feel there was a bubbling up of tension in the society I grew up in. There were inequalities. I went to a school where we had, 45 people per classroom. We had many of the people I went to school with, five generations of the families had not ever been employed. So there was that kind of sense of despair and desperation and kind of what intense poverty brings to people and into people's lives. And the whole mantra at kind of, I suppose, my young age was education is the way out of the poverty trap. The town I grew up in, which you might like to know about, Jude, had 25 pubs, 10 churches, and one library. And so the best place in the world that I spent so much of my early years was in that library, and literacy being to me one of the most absolutely vital, important skills for life, let alone for kind of leadership roles. Very unusually, school I went to, nobody had ever gone to university having done science before. And although my natural instincts, I think probably wanted to be a lawyer and bring peace in the world, partly because of the conflict I was growing up in, because the only, I suppose, highly respected member of the community that people went to with problems was the local GP. I decided I would try and get into medical school to become a GP. But I'd only been in medical school about 3 years when every sense that I wanted to be a GP stopped. And that was because I started to do my mental health placement. So my mental health placement was in a very large psychiatric institution. And, you walked in the door and you smelt the stale cabbage and you could sense and almost smell the kind of the despair and the desperation. And I was asked as a medical student to meet a patient and told, you mustn't close the door of the room. You've got to leave the door of the room. She's dangerous. You could be attacked. And I kind of looked at this woman in the eyes, and with my own kind of instinctive sense that if somebody's made a rule, does it make sense or should it be broken for the greater good? I kind of went in and closed the door and we started talking. And she'd been labeled as having schizophrenia, but the story she told me was one of systematic abuse by her father and brother year in and year out through all of her adolescent years. And for her, and the way she described it to me was, it was easier to live life in a state of unreality than it actually was to remember the terrible reality she suffered. So we spoke for about 2 hours, and that I sat there and I thought, physical pain, which is what I'd come to treat as a doctor, is one thing, but this is where I'm meant to be. My sense of justice and equalities and the need to understand people and the context they come from and help them understand their life opportunities. That to me is what I'm meant to do. So I decided at that point I would go into mental health. And that's kind of what I did. I changed into mental health. And then, as you rightly say, I've spent most of my clinical career working in primary care services out in communities. I've always worked on the basis, like the Churchill war map. Anywhere I've ever gone, you get a great big map on the wall and you map every single organization that could possibly help support my patients, the libraries, the dyslexia associations, the kind of the day centers, the clubs, the supportive initiatives going on, church groups, faith groups, all sorts of groups, football groups. You map them on a map. And I used to work on the basis, me and my teams, that every single one of these agencies is going to be working to support the recovery of my patients who have mental health problems by the time we've kind of left this place. So that's kind of part of, I suppose, the beginning of my journey. It's about values of understanding and listening to people who they are, not a label. It's about giving people and understanding their dreams and the opportunities that could give them a very different life if only we were skillful enough to kind of help that. And it's about community activation and mobilization. So that's what I took into my leadership roles as the medical director for mental health and dementia in London, and then the national clinical director for mental health in 2012.
Thank you. Really powerful story there also about your motivation and journey. I just remind and talk to everybody who's on the call and remind us, please let's make this a conversation. So do put your questions into the chat and I'll come in and out of them. So you painted us a picture of sort of your early years. How about painting us a picture of kind of the state of mental health services and where you think things are sort of not going well? And what needs to be put right?
Okay, I think if I can have your agreement, I'd like to kind of just go to 2012, because for me 2012 was when a lot of things changed in England about mental health services. So in 2012, I became the National Clinical Director. And I went in to NHS England, which had just formed. Health and Social Care Act had just been passed. And I thought I would be all about improving the standards of clinical care. That's what I thought I was doing. And then I started just doing a bit of research. I looked at newspapers, and I know that everybody who gets into a leadership role can expect at least one crisis. But my crisis at the beginning was that every one of them were saying mental health services are all bad. Everything's bad. Terrible things happen. There aren't enough beds. People aren't seen in time. So it was a really, really negative story throughout almost the entire press and media. The second thing is within the system, so within the kind of clinical and other systems, there was such amazing ignorance. I was really surprised. So people were saying things like, but isn't mental health and mental illness, isn't that just some social thing? And there's no evidence base, there's no effective treatment. So why would we want to invest in that? And mentally ill people, they're just some sort of a kind of a drain on the economy, aren't they? Because they're all on benefits and taking drugs. And, you know, they don't even, many of them aren't even allowed to vote. So why would we actually want to think about this? And I looked at that point on the main NHS information website. So there was lots of fabulous stuff about cancer and diabetes and respiratory breathing conditions. And then I looked at the mental health section, and there was about 5 pages. And it was about the schizos clinics and the use of the Mental Health Act. So an automatic link on the main information website of the link between severe mental health problems, violence, and restraint. And I realized that actually the leadership job I'd signed up to was not actually the job I thought it was, that this was about public education and communication. And so we looked at that website, and as one does, you find allies in very, very unusual places that you hadn't expected. So if you looked at that website within 4 years, we got amazing people with lived experience of mental health to tell their journey. We got fabulous, empathic, compassionate clinicians to talk about the effective treatments. So in 2012, we had maybe 10,000 people hit on the terrible website. By 2016, it had gone up to 32 million people a year were hitting on the website. So and when you can say to politicians and leaders, we've gone from 10,000 people to 2 million, now 8 million, now 32 million, people start listening. And those 32 million people told stories, asked, what is my mental health? Is it the same as my physical health, or is it equal to my physical health? How can I prevent me and my family becoming mentally ill? As I get older, can you be mentally healthy all your life? And where can I get good services when I need it? And the digital world was our friend, and social media was our friend. And I remember I did one what I thought would be a career deadening thing in my life. So at the end of 2012, I just got really slightly fed up with having radio interviews and pieces written about how negative it all was. So I was in a room with 42 journalists and media people. And I said to them, look, I'm probably going to say something to you that will just mean that I will be out of a job by the end of the week, but I'm going to say it because I think it has to be said. So I said, 1 in 4 of you in this room, because that's the statistics, will have had a mental health problem. Or 1 in 4 of the people that you know. And at the minute, all you're writing about is negative things. And because it's all negative, It means we can't recruit staff. We aren't able to get people to join the campaigns to improve things. It's very easy to criticize. Improvement is a whole different ball game. Is there any way, and that because of some of the things you're writing, we know that people are actively more suicidal? Could you become part of the solution, not part of the problem? And I am one very small woman in a job, but you have far more voice. You in the media have a much greater voice in today's world and in the modern world that we're coming into than people like me will ever have. So please, could you join this and help? And I think the media in England have been amazing. So we've kind of gone in 2012 when people were stigmatizing things to actually today, far more people being engaged, far more community organizations involved. And I think that's really helpful. But I'm not sure we've got yet. So you asked me what's wrong, what needs changing. I mean, there's still, the great thing about being a lifelong learner is that you never feel that you've achieved the nirvana. But for me, the things that are going right is we are seeing some more investment in mental health services, as Simon Stevens and Norman Lamb, who were two wonderful people that were in the leadership in my time, we set out the 5-year forward view plan. What I'd love to see more of is a real clarity about, well, what's the evidence we're following about what works? You know, we have the science evidence, randomized controlled trials, gold standard scientific research, but most good scientific evidence takes 17 years to implement. 17 years is a long time. So what other evidence do we have? We've got the modern digital world where the voices and the experience of people and their families and people with lived experiences or communities can say what's needed, can say what they find helpful. We have different ways in which people, clinicians and others in organizations working really hard to help people, they can say, this has worked. You can form a totally different form of evidence that I think would take us much faster. And I suppose for me, there's still, I'm not even sure if it hasn't slightly gone backwards, that balance between the art of medicine, the art of caregiving, and the science of it. And the whole thing about listening to individuals, listening to their story, helping them understand what they could get from their life, helping them get the resources they need, help them develop, modern parlance, care plans with advanced decisions. I think that needs a whole step change going forward. So I don't know if those are the kind of questions I'd love what people think.
Well, clearly something, because we've got some questions coming in. So let's turn to Ian, who wants us to bring us COVID into this. And I think there's a real danger, isn't there, that COVID is going to create its own mental health pandemic. And there's going to be a real long tail of sort of after COVID of something around mental health. So Ian, do you want to just come off mute and ask your question?
Hello there. Thank you. I'll try and keep it brief, and I'll read